time of the year. It's always exciting to give a seminar within UQDI because it's good fun to share our data with you. So today, actually, I picked Gaz and James to join me to give a seminar about melanoma. And initially, I didn't do that on purpose, but it turns out that Gaz and James are the last people from the lab who've actually gone to a conference and presented something. So I think Gaz went to the Brisbane Cancer Conference, and then James went to Lorne. And so they're going to share their stories with you today. But just before that, sorry, I'm just sharing my screen. Here it comes. Here we go. But just before that, we're going to be talking about melanoma and melanoma vascularization. There's an aspect of the lab that we don't necessarily talk about too much, which is all the clinical work that goes on in the background. And I thought, for once, I might talk about some of the clinical research that we're doing also in the lab that leads to this lab work. And this is especially topical because, as you saw, last week's seminar was also about melanoma, and this week is about melanoma too. And it's actually May is the melanoma month. It's the Melanoma and Skin Cancer Awareness Month, and yesterday was the World Melanoma Day. So this is actually quite topical. All right, so what is melanoma? We hear about it a lot. So it's cancer of the melanocytes. As you know, it's one of the most frequent cancers in Australia, and we have the reputation of having the highest world incidence. Definitely in Queensland, we are the world leading in terms of incidence of melanoma. And so it affects men more than women, but you see in a broad Australian sense, 1 in 13 men and 1 in 22 women by age 85 will have a melanoma. So this amounts to a large number of melanoma, a large number of deaths, and as you can see in these curves, is that the incidence and the mortality have been increasing, except for these past few years where you see a little dip in the mortality, and we'll talk about that. So when you're diagnosed with melanoma, you have to be staged because that indicates your prognosis. And essentially, stages 1 and 2 are local, so the melanoma is still in your skin. The difference between the two is how deep it goes. And in general rule, a 2 millimeter depth makes you, pushes you over to stage 2. And then after that, there is the invasion of the regional lymph nodes, stage 3. And then after that, there is distant metastasis, stage 4. And you can jump straight from a stage 1 to a stage 4. There is no continuum in this process. So at diagnosis, each of these stages gives you a prognosis. So, if you're diagnosed with a stage 1, you have, in general, about 95% survival at 15 years. But then stage 2, 3, and 4, you can see that the survival drops down to 10, 15%. Stage 3 being around 40% and about 60 to 70% for stage 2. So you see, there is really that categorization that's quite important. Most, importantly, is that we diagnose most people in the stage 1, so at the earliest stage of the disease, and this is really important. That's why, in general, melanoma has a good prognosis, so 91% chance of surviving over 5 years if you've been diagnosed with a melanoma, all things considered. That's because of the great effort to actually doing screening and skin checks and so on, and finding the melanomas early. So you see, this is data that we had from Queensland, 28,000 people over the past 20 or 30 years. And you can see that over 80% of melanomas are diagnosed at that early stage, the stage 1, and then there's the rest of them are stage 2. Very few are diagnosed at late stage and metastatic stage. The consequence of that, of so many people surviving, is that there is a large population who are survivors of melanoma that need to be constantly checked for their well-being and then their skin checks. So there is really a huge burden of this process. You've all heard about the progress in therapy of advanced disease, and so I've been putting here some of the examples of immune checkpoint inhibitors with the long-term survival that we can see with agents such as CTLA-4 inhibitors or PD-1 inhibitors, and the combination. But if you just look at the broader picture of melanoma treatment compared to what we have here in purple in chemotherapy, targeted therapies have pushed things a bit forward, but essentially on the long term, they don't maintain patients. It's really the immune interventions that constitute some long-term survivals. And the best one that we have currently is the combination of PD-1 and CTLA-4 blockade. And the hope is that as we add more things to these, we push these curves upwards and towards better survival. So one strategy that we've used about this success in treating people is to bring this treatment forward in terms of giving them to people with more early stage disease. And this is adjuvant strategies. So this is now giving these immune checkpoint inhibitors to people who don't have any disease detectable. So this is adjuvant. So their tumor has been removed, and because we know these people are high risk, we give them the tumor, the medication, and the related toxicity. So this is quite important for what's going to follow, because we need to really identify risk groups to give them adjuvant therapy. So a lot of toxicity emanates from these immune checkpoint inhibitors, and we need to give them to the right groups. And if you look at the early stage melanomas, so the stage 1s and 2s, and you break them down by different thickness categories, you can see that you have a range of possibilities, but that's still not good enough, because if you're a patient, you still don't know if you're going to be in this part of the curve, where you're going to be actually progressing rapidly, or if you're going to be in this part of the curve, where you're going to be a long-term survivor. So overall, you're always in doubt with the measurements that we currently have. And especially if you look at these really top 2 categories where most people are diagnosed, so these are places where you have 90% survival at 20 years, because we diagnose a lot of people in these 2 categories, there is actually, in terms of absolute number, most melanoma deaths come from these early stage melanomas. So most deaths stem from early stage melanoma. And this is really the challenge of finding these rare 4 to 5% that are going to be progressing among the large population of melanoma who are not going to be progressing, because that's the people that you want to treat. That's the best strategy to actually reduce the number of deaths in melanoma. So these are really tricky and challenging questions. How do we predict better who's going to be progressing and who's not going to be progressing? Well, we do sentinel lymph node biopsy currently. This is the accepted process for giving adjuvant therapy right now. And what you do is that you try to identify the first lymph node that drains the area of the tumor, and then resect it and see if it's invaded. It's an excellent prognostic indicator, as you can see here, with the separations of these 2 curves. But it's got some toxicity. It requires quite specialized teams. And practically speaking, it's only a third of patients who have an indication for sentinel lymph node biopsy that receive it in Queensland. So it doesn't really apply to everyone. And then if you look at that, the top of this curve, the people who are sentinel lymph node negative, there's still 20% of them who end up having recurrence and 10% who die from the disease. So overall, this is not a panacea. It's not that great. You see the sensitivity and the specificity of sentinel lymph node biopsy, at least in Queensland, it's not great. So people have therefore relied on trying to find other biomarkers, and there's 3 that are commercially available right now that rely on gene expression, and these are from results of gene expression microarrays comparing progressing and non-progressing people, and finding panels of genes that you run on paraffin sections from these patients. You see the curves separate really greatly, but then when you bring that into a real life situation of finding the 5% that will progress in all those people who have thin melanoma, well, that's that's actually what happens. You only identify one of the progressors out of the 5, and you identify a lot of people who are not going to progress. So this is related to a 20% sensitivity and 95% specificity. 99% of people for a test like that will receive the test with no benefit. This is the bottom line of this cutthroat paper that was just published recently. So this is the challenge. How can we improve the detection of these 5 people who are going to progress and die from the disease in the sea of all these people who are not going to progress? And these are why we've been establishing over the past few years, actually the last decade now, a number of study populations in Queensland, all in Queensland. So either hospital-based cohorts or more widely based community cohorts, specific projects on thin melanomas where we've been taking people who have died from thin melanoma and matching them to people who have survived thin melanoma, and then essentially using the whole cancer registry as a population cohort. And we've been running a number of studies in here. So just to briefly touch on some of this research. So the primary melanoma project, this is probably the most productive one, which started in 2010. We recruited about 800 patients at relatively advanced stages of local invasive melanoma. That was led by Adele Green with myself and Mark Smithers. So Adele Green's at QIMR, and Mark Smithers is here at the head of the melanoma unit at the PA. And we're very lucky to have Lena, who's done her PhD. So she's right now in dermatology training, but this is all the work of her PhD. So Lena looked at some of the classic markers such as thickness and ulceration. So these are tumor, well, let's say tumor indicators. But then she looked at the whole range of host variables, such as comorbidities that increase mortality, sun protective behavior that actually protects against new onset of melanomas. The tumor transection, if you do a partial biopsy, that deteriorates, your outcome. Statins, the use of statins, that improves it. So there's a range of host parameters that actually influence on melanoma outcomes. And this is again something similar. The thin melanoma course, this is work led by a postdoc in David Whiteman's lab and myself, Magdalena. So Magdalena is an MD PhD and she's a dermatologist in Sweden and working here for the past 2 or 3 years. And in conjunction with Sue, who's our research nurse. And so what Magdalena found was that scalp location was actually a key indicator of melanoma mortality for these thin melanomas. And, if I push again, in terms of the host influence, work by Lisa Byram, who's now a dermatologist, showing that sex and pregnancy are also things that strongly affect melanoma outcomes. So, female sex improves survival by 30%. So this is almost as good as PD-1 inhibitors. Pregnancy increases mortality by 60%. And this is probably through vascularization and increased vascularization. A pet one of mine, so the fact of having multiple tumors really affects outcomes. So this is the curve of people with only one melanoma, and then if they get a second one, their survival is less, and the third one, it's even less. And this has to be related to the host and how the first melanoma has changed the host. And this is something that we're exploring. And this is work that we did with our colleagues at the Queensland Cancer Registry. And finally, we've been exploring some biomarkers. So this was work by Casey, who did her PhD in the lab, and she's now at the end of her dermatology training. So hoping that we'll get her back for more research. But Casey examined some germline markers that could determine survival and affect survival, such as PARP1. Or she looked at infiltration of specific types of macrophages in the tumor, and establishing a score that could really separate people quite nicely to the same level and at the same strength as sentinel lymph node biopsy. The problem is that it didn't do better, so we can't really expand it. But we're finding every day new markers that we can use and add to this system. So there's really a push from our side, but also other labs in that UQDI, such as Mitch Stark's lab or Andrew Barber's lab, to try to find new markers that can help in identifying these rare few patients who are going to be progressing, but who actually constitute a large number of melanoma deaths. And we are focusing on the host factors, and especially in the host factors on the vascularization. So, and this is really one of the key projects that's happening in the lab. So now shifting towards the lab-based, it's because of our discovery of a population of endovascular progenitors that actually maintains homeostasis in the vascular system by differentiating into endothelial cells, differentiating endothelial cells and having self-renewal, but also participates in the formation of blood vessels in situations of new angiogenesis or neovascularization, such as wound healing or in the case of cancers. So what we're trying to identify is whether targeting these endovascular progenitors can actually help melanoma outcomes, and if the presence of these endovascular progenitors is actually a predictor of worse survival.